Okay, so I'm Brendon Prescott. I am the Deputy Chief Nurse of Southport and Formby and South Sefton CCGs. I'm also the Innovation Scout, obviously, for the two CCGs as well. And I was fortunate enough to be given the bursary to attend the trip to Denmark in the middle of October. So, as Lisa said, I just wanted to sort of reflect on some of the I guess learning points certainly from the trip. I guess a lot of these are. Oh, hang on, there we go. Good start. Stay calm. I will also be drawing on colleagues who also attended on the trip. So I also think that we have different perspectives, and it'd be interesting to see whether what I say resonates with them as well. So we actually attended the World Week of Health Innovation, which is a week-long event held in Odense, Denmark, like that, say Odense in Denmark, which is a variety of different events happening over a period of 5 days, including conferences. There were events, various activities going on, but basically all brought under the banner of health and innovation. So as you can imagine, you've got a lot of technical things going on, as well as things which are specifically health related as well. The links, therefore, with the Academic Health Science Network are plainly obvious as well in relation to innovative practice, perhaps, or exemplar practice, how it happens, how it can be spread, how it can be shared, and also bringing together a number of different individuals from a number of different backgrounds. So we attended a hacking event which went to talk about Edward Snowden in a very dark nightclub. You were there, Jen. You were there, Lisa, weren't you? Do you remember? It was a bit dodgy. But the good thing about that is it's just drawing in various individuals from various different backgrounds and different levels of expertise as well, and how they think that can help in terms of such things as. So that particular talk was related in terms of the sharing of information, specifically from a health perspective. We can all probably understand the issues that sharing health can bring across, or health records certainly across in this country. I'll touch on how it happens in Denmark a little bit later. So the idea is bringing people together from different backgrounds and seeing what can be shared, learned, and possibly utilised in your own health economy. So why I was interested in going, I guess, I'm a nurse by background, so obviously I'm sort of more, I guess, clinical quality perspective. But it's always been very insular. It's always about what happens in Sefton, never mind what happens in Liverpool, what happens in Merseyside. What was being useful was to see how things happen in a different health economy. Obviously, you've got some insight, perhaps, from your own previous experience of how things run. But for me, certainly, it was to go to see how things work in another European country, another North European country, and see whether there are similarities or differences, or to see how they do things differently. So, for those that don't know, and I was paying attention, as you can see from this, Lisa, there are 5 regions of Denmark, and that's broken down into 98 municipalities who each are able to raise their own taxes in order to fund health and social care, as well as direct funding coming from the government. So they can do things differently in the various provinces, and these changes happened in the mid-90s in terms of how they set themselves up. We were in Odense, is known as the it's southern Denmark region, and it was known as the rotten banana, because of the fact that it's not very built up. Villages and towns are spread out, but the population is relatively older than in other regions, and as you can imagine, there aren't that many cities in Denmark, and so younger people tend to migrate towards the larger cities, and as a consequence of that, it also brings its own challenges for southern Denmark in terms of trying to meet those challenges of the older population spread out unnecessarily altogether. So there's a little map. We were there, so lovely train journey from Copenhagen through all the lovely scenery and across the water, and that's the southern Denmark region there. It's kind of past as the rotten banana. Who's that? Anyone? Not you, Glyn. Not you, Abby. That's Hans Christian Andersen, who actually lived as a child in Odense. We visited the museum towards the end of one day. It was very good to see a local son. And here's another one. There's King Canute. Not the King Canute, I have to point out. There's a lot of Canutes in Denmark, but the legend of King Canute is that he got his chair out and he stuck it down in the water in the south coast and tried to hold the tide back. But the other version is that King Canute actually, because he was held up as a bit of a demigod in terms of all-seeing, all-powerful and all-knowing, well, he wants to show to his subjects that actually he can't stop nature and things will always happen. And I prefer that version than the first one, because let's be honest, we can't stop this big machine called health, no matter how hard we try almost. And it's accepting of that and knowing how, therefore, what your limitations are and what you can change rather than what you can't, which is of use. So I want to concentrate on the first couple of days, which I found really interesting, because we visited a number of different places in Odense, and the first place we went to was the University Hospital. The chap there talking away is Petter Jest, who was the medical director of the hospital, and as you can see, these are my slides. You probably can't read them now. They look really good on the computer, perhaps not so on here, but this is just the breakdown of the health system in Denmark, where there currently are 60 public hospitals, very small private sector. There are only 10 in Denmark. There's 2,000 GP practices and 1,100 specialists and 330 pharmacies across the region. Now, just to give you a bit of an idea as well, there are 5.6 million people living in Denmark, and we consider the population of the northwest of England is about 4.6 million. It's not that far off in terms of the northwest. I wanted to put this slide up because it was a case of, oh, I've seen that slide before, and I've also heard people talking about jumping off the burning platform, having to take relatively drastic action because of the situation that you find yourselves in. And essentially, the issues that were in Denmark are exactly the same issues we face here as a health system. In relation to an older population, therefore, as people get older, they tend to have a number of comorbidities. As a consequence of that, there's less money going to the tax system. The number of health professionals is falling. We're all, again, from a primary care perspective, all the GPs are retiring, and there'll be no practice nurses left this time next year. Just no panic, it'll be fine, I'm sure. But the point is that they're very similar in terms of the issues that we face in our own country. So what are they doing about it in Odense? Well, they're also looking to try to do things differently. Again, resonates in terms of what we are all trying to do in our respective organisations and across the northwest. And we were able then to access some of these particular events and locations to see, well, what are these things that are sort of doing perhaps slightly from what has been going on before, i.e. what you always do is what you'll always get. So again, the important thing to remember here as well is a lot of these aren't new things to us. I didn't go in there and think, wow, that's absolutely amazing, they've got like living labs, or wow, they're using telemedicine, because to a degree, I think all of us will have some experience of that in our own work environments. I suspect what they're trying to do there is to do it at scale. Okay, there's only 5.5 million people, but it's still relatively, I guess, important to consider. They are trying to do this as a whole scale change across Denmark, and not just like in Odense and across southern Denmark. So some of those we'll already, I said, we'll be aware of, have some knowledge of in terms of better communication, cooperation. We've already talked about collaboration here, about when a patient comes into hospital, what happened to them before, why did they end up in hospital, and when they're going out, how do we ensure that the care, aftercare, is being maintained consistently to hopefully ensure that patient doesn't end up in hospital again. Integrated care, again, no surprises. We think about, for example, where we are here. We have the Healthy Liverpool programme already up and running. Ourselves and Sefton, shaping Sefton. When you look at perhaps the objectives and the aims, not much difference in relation to those in terms of trying to have a bit more integrated approach to care for patients. The CoLab, Odense will talk about a little bit later on, and telemed. So they're things which, again, aren't necessarily new, but essentially the way in which they're trying to introduce them across a region is, I think, it's fair to say. So one of the things to do is whole-scale change in relation to how many hospitals do you have? Well, the idea is to reduce the number down to 21. So they're going to subsequently merge, as well as build 5 new hospitals look at various specific sites. Again, things that aren't new to us in terms of, we think about the discussions that are currently going on with the Royal and Aintree about what will be hosted where, for example, in relation to trauma, for example, or various surgical sites. And the plan is obviously is to treat most patients out in the primary sector. So these things, less hospitals, less beds, shift out to primary care, no difference to what we're trying to achieve the whole scale across England and certainly in the North West. We then went from the talk with the medical director down to AED. But before that, I wanted to show that what they're putting in place at the hospital is starting to make a difference in relation to patients coming through the doors when they're being seen, how long in terms of the 4-hour target. And I know, we are at the moment having a very difficult time on that, and there's a number of reasons for that. But they are starting to see some outcomes, which is, I guess, is key to anything that we try to do now, is try to have outcome measures which are beneficial to all stakeholders. So they are starting to see some differences. And what was quite enlightening in a way, I did with Schadenfreude, is when this is the chap from he's the director of A&E down in the University Hospital. That was one of his first slides he put up, and I don't think you can read that at the top, but that's from the hospital in Singapore, explaining that patients who come into the doors may have to wait 20 hours to be seen. So, put into context really, 4 hours, 12-hour breaches, 20 hours. So this is not, this is a universal issue, universal problem in terms of patient flow coming through one particular gateway of A&E and what happens after that as well. So I took a little bit of heart from that, because you feel as if you're not alone in terms of the problems that you're facing. So in relation to what they're trying to do different in A&E, for example, they're not sort of, it's not rocket science, but essentially they're using their most senior medics to be the first point of contact with patients who walk through the doors of A&E. Now, I know that there is a drive for consultant-led A&E at all times, certainly when we're thinking about 7-day working, but the first person, it won't be an F1, it won't be the F2, it won't be a triage nurse. The patient gets in, gets clerked in, the first person to clap eyes on them will be a senior consultant. So it's a kind of quick decision making in terms of what's going to happen with that patient. And they're concentrating on what the patient presents with, because, as they pointed out, in terms of symptoms, there's roughly about 30, which kind of is a catch-all. And by that, and also in terms of psychiatric symptoms as well, and by that you're then able to start making clinical decisions about what you're going to do with the patient, i.e. turn the patient round at the door or admit. So that was interesting. This one's not going to come out very well, but basically what this is the tracking system that they have in place in AED. So who's going to be seeing them when? These, you can't really read them, but essentially these are various health professionals who will be seeing that patient through their patient journey and when that plan will be. So there's a 5-minute wait between each one. If it's a longer assessment, maybe 10 minutes. But the idea is they're planning that as soon as it comes through the door. A&E itself, what they've shown, and again, in terms of sitting in various contract quality meetings across Liverpool and Sefton, one of the big issues that we have to deal with is sickness and absence. This relates specifically to A&E, but high pressure environment. Again, outcomes, things that they've done to change the way in which they work have had an impact. They've halved the sickness rates. They've been able to reduce the number of patients being admitted into the hospital by over 20%, which in effect then relates to a reduction of 38 beds in terms of the bed stock of the hospital, and also a reduction in the patients being readmitted within 30 days by 15%. So again, these are hard facts that they've been able to sort of measure. I think that's exactly what we're trying to achieve here in Merseyside as well. But I guess what this brought home to me was the fact that the change in practice in terms of the way they were doing things has actually reaped benefits for hospital in Urbans. This isn't quick fit in this is the living lab, and this was again for me very interesting. Hadn't seen anything like this before, and basically what this is a mock setup of various elements of healthcare that they're looking to try to improve, innovate on. So they've got an ambulance there with bits and bobs inside, various bits of kit, technology, for example. that they will be able to test in an environment to determine whether it'll be applicable, either, for example, for paramedics. You can see in the far distance there as well, a few little doors and chutes and things, and that was basically a mock-up of what the new university hospital will look like in relation to their waste and laundry disposal systems, which was, I think, what I liked about this was the honesty, but also the vision that they had, because we thought, well, hey, what? So you're going to have these things, you pull out walls. Oh, yes, it's good, yes. You walk over here, you pull this, you stick it in there, and it goes down to the laundry, and done. And you press a button, and the new stuff comes out, you take it out, and you put it on the bed, it's great. Like, what, no baskets? No baskets, no baskets. I said, well, how does that work? Well, you open it, you put it in, you shut it, and the magic happens, and then it happens, and then it comes out. So that's how far they are in terms of their planning. They've got the idea, but they're working through the actual logistics of how it will be sucked up down various pipes, down to the laundry, and new stuff will come up. But that was interesting, actually. And we were like, wow, magic happens. I'll write that down. Magic happens. That's just a cynic in me, but it was very, very refreshing to see. And what I liked about this, and I know, Glyn, you've been experience of labs before, haven't you? This kind of living lab approach. Isn't the one like it was, because I really liked about this, when you're walking around, it was not only physical space, but the space to actually do this, to plan these things out. I think it's probably done on smaller scales. And I know, for example, at the Royal, I think there's something similar in terms of you've really started to build up your mock rooms, etc.
Yeah, mock rooms for new hospitals, that's up now.
Yeah. But I think like this was that, it's kind of it was wide in terms of, it wasn't just about the hospital, it was community. And I've got another slide here which shows what they're doing in terms of patient records. So they have shared care. And I was at a meeting yesterday, funny enough, at Aintree, we were talking about, oh, wouldn't it be lovely if we had a card that wherever the patient kept on them, and wherever they went, the GPs, the pharmacy, through A&E for an outpatient appointment, the opticians, it gets swiped and bang, what you get is all the information about the patient in terms of their primary care episodes, when they were last in, what their specific problems are, how they're being treated, if they're being treated, how successful has the treatment been in terms of observations. And we talk about this, and we talk about various systems linking up. They've got it, and I did have a slide, but I actually cut it out, unfortunately, because it was basically a card. I thought, well, I can't talk to that. But basically, it's probably quite an important slide in terms of, in Denmark, they just have the common patient record. Now, the idea behind that is not just the logistics, but it's also the culture about sharing information, which is a big thing, not only for the individual, but also in terms of how we get over various healthcare organisations. And I think one of those groups would be GPs in terms of being the gatekeepers of information and getting it out. Now, there's absolutely importance around information governance, but these things actually do make a difference to patient care, the knowledge, the information that can actually influence decision making, clinical decision making. But it doesn't seem to be an issue there, and I guess when we were talking about this, the chap did say, well, actually, it's not a bigger, from a cultural perspective, it's not such a big issue. We then went to, again, another, this was actually the living lab. Now, Glyn, you know what that means, don't you? I think you... Yeah. Everyday technology. And the guy who took us around the living lab was really interesting in the fact he said, so, what do you mean by technology? And we were all thinking, oh, computers or chutes you can throw things down, that magic happens. But essentially everyday technology are glasses, basically. You put a pair of glasses on, I couldn't see, I can see now, wonderful, that's your technology. And that's how simple it can be, right up to various bits of kit, like a chair that when you fall over will go down to the ground, you can be rolled onto it and it will bring you back up again. So again, mock-ups of patients' own homes, and various bits of kits and equipment which allow the patient to live more independently. And if they are faced with individual challenges, how can they be addressed? We also then went to the Centre for Welfare Technology. And again, this isn't new stuff. This isn't, and if you can't read that, I apologise. But this what we're talking about here is that we live our lives, we do as we want, we don't even think of it that we take care of ourselves. It's what we do. And I guess that's an interesting, because again, this is cultural. It's not just about bits of kit. It's a kind of perception shift. And I always think that, we've had the NHS for what, since 48? 40, you remember, don't you, Jen? 48, wasn't it? 48? With Nye Bevans kicking it all off. So we're used to being done too, especially in the early years probably, and as a consequence of that we probably expect more of our healthcare providers. This idea that it's important that we try to, as much as possible, provide independence for people to make their own decisions about their health, informed decisions, but also them take responsibility on for their health as well. The idea behind the Centre for Welfare Technology is basically to support people to live an independent life. I'll slip over that slide because it's not the best to read, unfortunately. But essentially, it's about trying to achieve quality of living at a good price. So what the Centre for Welfare Technology does is it can bring companies together with the municipalities, test bits of kit out to determine whether they will be of use for patients to use in their own homes. This is probably what I'll take away with me from the visit was, we talk about this, but this idea that in terms of care, there are less warm hands. The idea as a nurse is I go to someone's bedside or I go to them in their own home, I put my hands on them and I'll take the blood pressure and I'll pat them on the back and I'll talk to them and we'll try to sort out their particular problems. But as the workforce reduces, as the number of people get older, there really is no other option but to look at this idea of cold hands technology. So this idea that in the living lab, we have this room set up where you get your BP taken, it goes down various modem down to wherever to some server and gets uploaded on your personal health record. The same with your blood glucose. The same with your ketone meter if you're a type 1 diabetic. And that information then is relayed back to you by someone over the phone or by Skype, as opposed to someone being in the room with you. Now, to me, it's a hard concept to grasp as a nurse because you do your job for a reason that you want to sort of be there talking to people, making contact with people, hopefully trying to improve their current state. This idea doing it from afar really is a pragmatic decision, but it has to happen because without the technology we're not going to be able to do what we currently do in the next 5-10 years. So it was interesting to see how they were looking to build on that as a region and work some of these ideas through, these innovations through. Again, not all perhaps would work. They did show one time and time again. It was they had Fuji, Fujitsu, wasn't it? From Japan, who wanted to test bed their aid in order to allow people with perhaps a stroke, for example, and they may have some left-sided weakness or whatever, and trying to get them out of the chair and upright. And they had this lovely bit of kit. There's a basic robot that can come down to patient level, and with support, the patient then is eased up gently, as opposed to someone being in the room doing it for them. And I guess that was one thing that they are trying to work through. But what was good, I think, was also the fact that there's some things which perhaps won't be as, wonderful as they first think, or be as useful as they would hope. But having the opportunity to test it out, I think, is key. So, I guess some of the thoughts from my trip were that it was good to see a bit of joining up happening and bringing people together in a forum that they could share ideas, perhaps try to make connections of where it might be applicable to. Their plans for the healthcare sector and specifically of the hospitals is ambitious, but when we talked to various individuals as well, to be honest, in some ways, I think what's happened here over the last 3 or 4 months, I think what's happening down the road at the Royal is no less ambitious, which we're already sort of trying to make happen in Merseyside. The new hospital is due to open up in 2021. And to be fair, I do think that one particular talk, we spoke to one of the architects who were designing the building, and I think, who asked the question, why is it so spread out? It was literally on a site of about half a mile. Why have you built up rather than across? Because obviously people having to walk long distances, and it was down to the planning procedures. And he says, "Oh, maybe we should have thought about that." You're like, what? To be fair, the colleague from the Royal really sort of had a good discussion with him, to the point that he was thinking of coming across to see her and how things are happening here, because 2017, it's still a few years before they open up, and I think it's still looking to sort of chop and change what they do, which was quite refreshing actually. Speaking about long distances, and I'm the only person to see it, but they did have these wonderful bits of technology called scooters, adult scooters that basically, because the hospital is huge, it's about half a mile long corridor, and essentially, if people are going from one end to the other, they can hop on a scooter and scoot along. Well, I thought it was good anyway, but I guess the small things and your small minds. You know, as I mentioned before, the challenges faced in Denmark are no different to what we're facing here in England and the UK. What was interesting is that I think there was more room for planning at a local level. I know the idea behind the white paper was that it was supposed to happen here in this country. I won't say any more about that. In relation to WIN itself, I think, and I went into this quite innocently, but I do think it's a bit of a shop window for them as well. I'm not saying that there's anything wrong with that. It's probably right that they are able to sort of showcase what they are currently offering for the population of Denmark, but also how they can help other, or hopefully collaborate with other health economies across Europe. This idea, and we've talked about this already today in terms of resource and time and space to innovate, it's a challenge for anyone in any organisation. There just isn't that around, but when it is available, it's trying to make best use of that, and certainly that's what they're trying to do in Odense. You know, not particularly different to what we're doing in terms of how systems are set up at a local level. We have to get our heads around this use of, and that could be anything in terms of telemedicine, in how we communicate, in how we collaborate and share information across the various health care interfaces. It was refreshing for me to be able to see how it works differently. And just to say thank you for giving me the opportunity to go. Thank you.